good afternoon, good evening, depending on where you are. We'll just give folks just maybe a minute or two to join. I anticipate that there's going to be good attendance to this session. I'm excited about it. So we will allow people to join. But also because I think we have quite a lot of content to cover from the incredible speakers we have. And also because the sessions are recorded, we can also start and people can look back if they missed some sessions. So it is the top of the hour. Welcome everyone to this month's session of the Africa Cancer Research and Control ECHO. My name is John Black Kabuche. I am a medical doctor at the Uganda Cancer Institute in Kampala in Uganda. And I'm also working as a researcher at Stockholm University in Sweden, at the Department of Computer Science. I like to do things around digital health. And one of the projects I've worked on has been around cervical cancer screening. So the topic of today is dear to me on HPV and HPV related, not only cancers, but HPV related conditions, as well as the efforts that are ongoing on controlling HPV in the African continent. That's really our focus today. So welcome. I'm kind of blabbering as I allow people to join, but I won't wait for so long before we start. We ask that if your bandwidth allows, you can have your video on, then people can see if you are following, if you're nodding. And I think when you have video on, you're also a little bit more attentive. You don't go on scrolling or, I don't know, do something on the sides. So you can have video on, but keep the sound off. Or maybe that is something that's already controlled by the host, that people can't turn their videos on. I don't know. In any case, we're going to have slides presented, and then there will be less eyes on you when you're when you have your video on. So for those who have just joined us, we're just giving people a few moments before we start the session. And I wanted to just in the meantime to project so that people who are joining us know that they are in the right place. I don't think anyone is thinking that they're lost. Okay, I think we should start now. Yes, we should start now. So do this. Yes, just to put that there. Yeah, then people can see that they're in the right place. So once again, good afternoon for those who are in, I guess, in where the host is in Nairobi, or if it's good evening. But I know we have people joining from different countries. So good morning, good afternoon, good evening, depending on where you're joining us from. Thank you for joining us today on this month's session of the Africa Cancer Research and Control ECHO. The topic today is HPV control and HPV-related cancers. Well, as I said, more than cancers in Africa. And we do have two incredible speakers, which we're very honored that they have agreed to speak. I'll introduce them, and then we will have one speak, and then we'll have some questions, and then Leon will be speaking after. Just some housekeeping. The sessions are recorded, so we assume you've given us your consent to record. because we know there are some people who might not be present and want to join, want to listen in. So we record the sessions and we upload them on a YouTube channel. So you can actually look back on the previous sessions. The echo runs monthly on different topics across the entire cancer control continuum, from prevention and screening and awareness, all the way to treatment and research and palliative care and advocacy. So we have a wide range of topics that are being discussed. So you can find those on the YouTube channel, and I think someone in the host in the Echo Hub can post a link to that if you don't know. Otherwise, you can just search on YouTube and you find the Africa Cancer Research and Control Echo. But without further ado, I will now introduce the first speaker, who is Laia, who will be giving us what we would call a case presentation. But as I say, this is not really like one single case. It's a special kind of echo where we look at not only a single case in terms of a patient, but also a condition. So Laia Almene is a medical doctor, has a medical degree from University of Barcelona, and specializes in preventive medicine and public health. She also has a master's in epidemiology and public health, and a PhD. And she has done a lot of work on human papilloma virus DNA prevalence and type-specific distribution in invasive cancers of the cervix, vulva, vagina, anus, penis, and head and neck. I think this speaks to the topic for today, because we are looking at not only cervical cancer, where we know there's a lot of traction in that regard when it comes to cervical cancer, but HPV is a nasty virus that has a lot more problems, and Laia is going to be talking about those. And the idea improve access to diagnostic testing, strengthening laboratory systems, and he has been working a lot in Sub-Saharan Africa as well as in Southeast Asia. So I'll now allow Laia to project your slides and yeah, take it away.
Thank you. Can you hear me? Yes. And I am sharing correctly the slides. Do you?
Yes.
Yes.
Looking good.
Okay. Thank you very much. Thank you for the invitation. And as you have mentioned, I will give an overview of the human papilloma virus and all the HPV related diseases, not only cervical cancer, as we have mentioned before. So the main topic will be to give an overview of the burden of HPV related cancers and also other diseases. It's not now. So here are the contents, very simple. We will talk about HPV and HPV-related diseases, cancer and non-cancer. And then I will talk about HPV attributable fractions and genotype distribution within these HPV-related diseases to better understand the burden of the disease. And then at the end, we will talk about mainly incidence rates in different cancers related to HPV and also the other conditions and the trends. So starting from only one slide to mention that human papillomavirus is a DNA virus that we have characterized, and there are more than 200 genotypes of this virus. They are named by numbers when they were discovered, and they have different classification by different different characteristics. And one of these classifications is regarding the risk of oncogenicity of these viruses, of these genotypes. And as you can see here, the International Agency for Research in Cancer, in the last monograph that review the oncogenic risk of these human papillomavirus genotypes, they classified the HPVs in high risk oncogenicity, that are those ones that are classified as one level. And here we have HPV 16, 18, and all of these types. Then we have the 2A, 2B, that are the HPV genotypes that are classified as probable, possible, high risk oncogenic. And then we have other types like 6 and 11 that are classified as low risk oncogenic HPV types. Regarding the HPV-related diseases related to high-risk oncogenic types, we have that HPV high-risk types are associated etiologically to different cancer in different anatomical sites. Here we have in the slide the different types of cancer that are related to high-risk HPV types. We have in the cervix that the HPV is related to cervical cancer, and also to the preneoplastic lesions that precedes this invasive cancer, that these are the ones that are low grade preneoplastic lesions, CIN1, and then the high grade preneoplastic lesions. Then in other sites beside cervix, in the anogenital area, we have that HPV high-risk types are related etiologically to vulvar cancer, vaginal cancer, anal cancer, and penile cancer. And then we have also in the head and neck area that HPV is related to different type of cancers. Oropharyngeal cancer, mainly oropharynx is the anatomical location within the head and neck where the HPV is more associated etiologically to this type of cancers. And then, as I will explain in the next slide, to a less extent, HPV is etiologically related also to oral cavity cancer, laryngeal cancer, and now we are also trying to disentangle the etiologically relation and the attributable fractions in the nasopharynx and the sinonasal cancers. Within this type of cancers, the attributable fraction, so this is the proportion of cancers that are related etiologically, causally to HPV, is different from the different anatomical sites. So we have, for example, that for cervical cancer, it is well established that the HPV is a necessary cause of cervical cancers. This is that almost all cervical cancer cases have as an etiological risk an HPV persistent infection. And then when we go to other anogenital sites and head and neck cancers, we see that this proportion of HPV attributable cases differs from the different anatomical sites. So, for example, in anal cancer, the proportion of cases related to HPV causally is more than 90%. Then in vaginal cancer, approximately 3 out of 4 vaginal cancer patients are caused by HPV. Then we have half of penile cancers are etiologically related to the virus. And then to a less extent, we have vulvar cancer, for example, an oropharyngeal cancer, in which a third of the cases are related to HPV. And then oral cavity laryngeal cancer, we have done less than 5% of the cases are etiologically related to the virus. In those cancers where the HPV is not the most frequent etiological factor, we have different factors that are related, are multifactorial etiologically related cancers, like in oropharyngeal cancer, where we have in oral cavity and laryngeal cancer, we have also other risk factors like tobacco and alcohol consumption. Here we have, so we come from here. I am going to detail a little bit about oropharyngeal cancer because in the other anatomical sites, the HPV attributable fractions have very slight differences between geographical regions. But in oropharyngeal cancer, there is a very huge differences in the attributable fraction by different geographical regions. Here we have a meta-analysis, a systematic review published a few years ago that performed by IARC, the International Agency for Research on Cancer, where they review all the published reports regarding the HPV attributable fractions in oropharyngeal cancer in order to see these differences between regions that I commented before. And what they found, this is the figure. I don't pretend that you see its details because it's very small, but there is a very huge variability of HPV DNA detection in oropharyngeal cancer by the different studies. I have put here Africa. One of the highlights that you can see is that there are very few studies reporting HPV attributable fractions in oropharyngeal cancer and with small sample sizes. And what they reported is this variability in the HPV DNA detection. You can see it here by the different regions. Here, I have also added that there was a correction by another causality biomarker that is P16. And if we go to DNA plus P16 positivity, we have here, you can see that in North America and some Nordic European countries, the vast majority of the oropharyngeal cancer patients have as an etiological risk factor the ADHPV. But when we go to other regions in the world, these attributable fractions are lower. As in Africa, you can see here, we have a 22% proportion of cases related to HPV. We have seen the related diseases to high-risk oncogenic types. We have seen and reviewed the HPV attributable fractions in the different anatomical sites. And now we are going to review which are the types that are etiologically involved in these HPV positive cancers in the different anatomical sites. Here you have a summary of the distribution of the genotypes, HPV genotypes in cervical cancer. HPV 16 is by far the most common type with more than 60% of the positive cases. And then is followed by HPV 18 is the second one. And then we have 45, 33, and other high-risk types. Now, if you look for the overall picture, including all the anatomical sites and cancer related to HPV that I have mentioned before, you see here cervical cancer, vulvar, vagina, anal, penile, and within the head and neck, oropharyngeal cancer, oral cavity, and laryngeal cancer. You have here the distribution within the HPV positive cases of the different HPV genotypes, which are the main highlights that we can see in this figure. That, as I mentioned before, in cervical cancer, HPV 16 is by far the most frequent type, followed by HPV 18. And we see that vaginal cancer has a similar distribution of HPV genotypes compared to cervical cancer. Then for the other anatomical sites and cancers, we have that HPV 16 is more frequent than in cervical and vaginal cancer for vulvar cancer, for anal, penile, oropharyngeal, and oral cavity cancer. And there is an exception for laryngeal cancer that it has been reported in different publications, scientific publications, that we see a more heterogeneity in the distribution of HPV genotypes in this type of cancer. Okay, now we are moving to the burden, the incidence rates and mortality rates. So we start with cervical cancer. We have that the incidence of cervical cancer, this is the new cases that are diagnosed each year worldwide. Those are estimations from Globocan, and for 2022, we have that more than 600,000 new cases of cervical cancer are diagnosed worldwide each year. And specifically, this is for 2022. And here you have the distribution. Now I will explain it later. And then for the mortality, we have that almost 350,000 deaths for cervical cancer are produced in the world in 2022. If we go to women, the young women from 15 to 44 years old, cervical cancer is the third most common cancer after breast and thyroid cancer, and the second only to breast cancer in terms of mortality. One of the things that I want to highlight here is the geographical incidence rates and mortality rates. You can see that the darker colors are the ones that show the highest incidence and mortality rates. And you can see that those ones are concentrated in Latin America and the Caribbean, Sub-Saharan Africa, and Southeast Asia. This is an analysis of the cervical cancer burden by country income in 2022. And this is to show that cervical cancer is equal to social inequality. With a decrease of the country income, you can see here countries with high income, upper middle, lower middle, and low. And here are the incidence. Threshold that the WHO has defined as the one to campaign that was launched in 2020, that the countries that achieves lower than 4 new cases newly diagnosed, of cervical cancers have declined in many regions of the world over the past 3 decades, particularly in Latin America, in Asia, in Western Europe, and North America. But the rates and burden of disease remain high worldwide. And however, there are countries with markedly increasing trends, especially in Sub-Saharan Africa and Eastern Europe. For example, here you can see it in Eastern Europe, where there are countries still that these incidence rates for cervical cancer are still increasing. This is a slide where you can see the burden in absolute numbers. Here are the numbers of new cases diagnosed each year. In orange, the ones that are attributed to HPV, and in blue, the ones that they are not attributed to HPV. And you can see the burden, the high burden related to HPV. HPV-related cancers accounts for 4.5% of all new cancers diagnosed worldwide each year, 8.6% of cancers in women, and 0.8% in men. You can see also in this slide that for the malignancies, the cancers related to HPV, the highest burden is related to cervical cancer, with more than 80% of the cancers related to HPV are from cervical cancers, followed by anal site and then oropharyngeal cancers. Regarding the incidence, I missed here in a slide that I had it and I see that I don't have it now, but I had a slide with the incidence for anogenital beyond cervical cancer and head and neck cancer related to HPV. And what I wanted to show in this slide, there were two maps with the incidence and their geographical distribution. And it was only to show that the incidence rates for the other cancers besides cervical cancer are much more lower than cervical cancer, and also that the geographical distribution is not the same that for cervical cancer. For example, in head and neck cancers is just the opposite. We have seen that the highest incidence rates for cervical cancers were shown in Latin America, in Sub-Saharan Africa, and some countries in Asia. And when we go to head and neck cancers related to HPV, we see the opposite geographical distribution with a higher incidence rates in countries with a higher income developing index. Now moving from the incidence trends we have seen for cervical cancer, and now I will show you some data for the trends in oropharyngeal cancer, in anal cancer, in vulvar and vaginal cancer. This slide is for oropharyngeal cancer. This is a report a few years ago. This is an analysis for different countries of registries across time, and it was reported that there is an increase in several countries. There is an increase of the rates of the incidence rates of oropharyngeal cancer, both in men and women. More than 20 countries of the ones that were analyzed and 23 countries for women showed this increase in incident trends for oropharyngeal cancer, and with an annual percentage change more than 3% per year in both genders. For anal cancer, it has been reported also in this part of the slide. There is an increasing trend, both in male and females for different countries in the incidence rates. And also in a recently published analysis of the burden of anal squamous cell carcinoma cancer, where HPV is related in more than 90% of the cases, it was reported that women contributed with 2/3 of the global burden of this anal cancer, and the majority of these cases, both in men and women, occur in highest resource countries. This is a slide of a similar analysis, but this for vulvar cancer and vaginal cancer. And it was reported an increase in incidence in vulvar cancer, particularly in women less than 60 years. You can see here the green is the incident rates across time for vulvar cancer in different countries. The red is vaginal. You can see that there is a slight increasing trend for vulvar cancer incidence rates in different countries, and it's not happening the same for vaginal cancer. And here you can see in this part of the slide that this increase is more important in women that are younger women. Moving to other type of diseases related to HPV, beyond cancer and preneoplastic lesions, we have that HPV is related also to other diseases. These are anogenital warts and recurrent respiratory papillomatosis. The types that are involved in these diseases, in these conditions, are mainly HPV 6 and 11. So we have in anogenital warts, HPV 6 and 11 are related to these conditions in a 90% of the cases, whereas in papillomatosis, recurrent respiratory papillomatosis, almost all of the cases are etiologically related to HPV 6 and 11. So these are types that are considered low risk of oncogenicity, but of cancers, but they are the types that are involved in a majority of the cases of the conditions of anogenital warts and recurrent respiratory papillomatosis. Regarding anogenital warts, which are mainly caused, as I mentioned before, by HPV 6 and 11, those warts are the most frequent manifestation of HPV infection. And we have limited information about the burden, but there was a systematic review updated up to 2016 that reported an annual incidence of genital warts that was between 85 and 205 cases per 100,000 people, and was similar for both sexes, with the highest incidence peak under 30 years old. And then for recurrent respiratory papillomatosis, the incidence, it doesn't show a very high incidence for this condition. We have two entities for RRP, the one which the onset is in young people, and then this is the juvenile RRP. Then we have another entity that is the adult onset, that is the adult RRP. As I mentioned before, this condition is mainly caused by the HPV 6 and 11, and one of the observations also for anogenital warts that we have seen a decrease in the incidence of these conditions by the introduction of HPV prophylactic vaccination. And with this, I want to acknowledge all my team and you for your attention, and happy to answer your questions. Many thanks.
Thank you so much, Laia, for this very data-rich presentation. I think I still need more time to process it, so I'm going to look back. And of course, if you're like me, we have the slides from Laia, and we also have the recordings. But I think the take-home message, which we kind of us knew, was that HPV is a nasty virus, and it is causing a lot more problems than we might think about. Of course, there is a lot of discussion about cervical cancer, but there is a lot more problems that HPV is causing, and also that it is not one virus. It is very many different viruses that behave differently. And so we should not let down. We should persist on figuring out how to eliminate it, how to prevent it. It's nice that there is a call to eliminate cervical cancer as one of the things that HPV causes, but we also need to essentially eliminate HPV. And maybe you have some comments on what each individual person should do. Yes, there is public health programs like vaccination, but maybe what each individual one of us on this call could do, that would be also helpful. For the audience, you can type in the chat and you can ask questions. For now, I think there's someone who has asked about the distribution of HPV-related anal cancers by HPV genotype across males and females. And I think that was one of the slides that you presented, Laia.
So the question, sorry, is about the HPV genotype distribution?
So Jean-Paul asks, what is the distribution of HPV-related anal cancers by HPV genotype across males and females?
Okay. So males and within the positive ones, the HPV genotype distribution in anal cancer is very similar from males to females. Where we find differences is with HIV positive population, where there is a slight decrease on HPV 16 and a higher increase of other HPV types with more multiple infections.
Yeah. Okay, so Jean-Paul, I hope you got the answer. If you have questions, please type them in the chat. The speakers are going to be there and they'll give responses to these. I have a question of my own before I let you go, Laia. And that is something to do with if you have a comment about the transmission, how the virus moves from one person to another. We kind of know that this is a sexually transmitted virus, at least for cervical cancer. Does that apply for oropharyngeal and anal? And how does that change or how does that relate to the, let's say, sexual behaviors across populations? Do you have a comment on that?
Yes, I am sorry that with the time restriction, I only give an overview of the related diseases and burden, and I have not gone into the details of the natural history of but this is a very important and interesting question. So HPV, as you mentioned, is related to many diseases and is the most frequent sexually transmitted infection, more than HIV, more than chlamydia, gonococcus. So it is estimated that the sexual active people, most of them, like more than 80%, will have contact with the viral once in their life. But the good news is that almost all, more than 90%, will clear this infection without anything. So the body clears the infection and that's it. The main ways of transmission is sexual behavior in all the anatomical sites, in anal, penile, vaginal, vulvar, and also through oral sex and within the sex activity with the head and neck also.
Thank you. So again, if you have more questions, you can put them, and I think Leah will also be looking at the chat, so she can type some responses to you. But I want us to quickly move on to Troy. But I think there's one last question where before we let you go, Leah, which
Yes.
has just come in. How do women contribute to the second second, third anal cancer globally? Why has there been an increase of cervical cancer and breast cancer plus thyroid? I don't know if you have an answer to that.
Yes, the first part of the question I don't know if I am getting correctly. I understand that from my slide that I mentioned about anal cancer, that 2/3 of the cases, the absolute number of cases, are in women. I don't know if this is the part of the question.
Probably that, yeah, I see that is what
Yes.
Rico is asking.
Okay, so the in anal cancer, that's super interesting because there are different groups, different risk groups regarding if you are HIV positive or negative, if you are men or women, your sexual orientation. So within these variables, you have very different risk of anal incidence rates. And the higher risk is in HIV positive population, more in MSM, in men that have sex with men. This is the group that have the higher risk, but when we go to the absolute number of new anal cancer cases diagnosed each year, the majority of the anal cancers are happening in women, immunocompetent HIV negative women. And this is mathematical. It's because of you can have a lower incidence rate, but you have more people that are susceptible, more women, immunocompetent women. And this is why then, by the combination of having a lot of susceptible women, although the incidence rate is lower compared to other groups, this makes that overall, most of the cases, anal cases that are diagnosed each year, comes from women that are immunocompetent. I don't know if I have explained myself. It's a little bit complicated about epidemiology, but this is the explanation. And why there has been an increase in cervical cancer, this is, for example, in Eastern countries or in some countries in Africa, or we can change it, no, and also make the lecture why have decreased in other parts of the world. Is this it's related to the implementation and the good implementation of the different preventive strategies that we have. For example, cervical cancer screening. In the places where we have very good programs of cervical cancer screening, in these places there has been a decrease in the incidence trends of cervical cancer, whereas in other places where these programs are not implemented or not well implemented, we have seen an unstable or increase of the cervical cancer incident rates.
Thank you, Leah. And I guess on that note, we can switch to Troy, who is going to talk to us about the efforts that are ongoing, especially from CHAI, Clinton Health Access Initiative, which has been doing a lot of work around access to diagnostics, access to supplies in Africa, but also globally. So Troy, please take it away and tell us how does where do we stand? What is the progress? How is the market coming up? And if there's more that we need to know about the preventive and the efforts to address cervical cancer and other HPV-related conditions.
Thank you, Dr. John Black. I appreciate that introduction and also just the framing from the beginning that you gave and that was really brought to value and picture with Dr. Laya's presentation as well. I really don't always get to spend a lot of time thinking about all the different cancers that are affected by HPV. And it was really helpful to hear that. Part of my framing will be about the global landscape for HPV testing, so why it matters, how it works, what some of the technologies are that are available today, what it's going to take to continue to scale that effectively in low and middle income countries or high burden countries. But the main focus there for many countries is cervical cancer. And so it's really helpful to have this framing about there's a broader value here that we need to think about for where HPV testing can go, even if we start with cervical cancer or have some momentum there. So thanks for setting that up. My name is Troy Morell. I'm a global director for diagnostics at CHAI. CHAI is an NGO that we have offices in about 30 countries across sub-Saharan Africa, South and East Asia. We work closely with ministries of health on their public programs as a technical advisor for HPV testing, helping them get their lab set up, helping lab health system development, health financing planning, and most often we work within their cervical cancer programs for HPV testing. But we work with a wide range of organizations that are critical for HPV testing. That includes patient advocates, people who are involved in developing or training staff at the community level, at the clinical level, and groups that bring education and public awareness to this issue. So really, really appreciate the invitation here, Dr. John Black, to speak. And I'll go ahead and jump in and see where we can go. Next slide, please. Great. Well, Dr. Laya has covered a lot of this already. Cervical cancer, which is our main focus within HPV testing, has over 600,000 cases annually right now, almost 350,000 deaths. 90% of that burden is in low and middle income countries. And it's worth calling out that there's a much higher risk for this with women living with HIV. So this is the fourth most common cancer in women globally. And I think Dr. Laya laid out some of the high-risk genotypes in particular, 16 and 18 causing a lot of cases, but there's a wider set of genotypes that matter. And the tests that we're going to get into have been trying to address that. There are tests that focus on just that group 1 set of genotypes. There's some that are trying to look beyond that. And we have to think about what the right case is depending on your country and where to go. Next slide, please. The other key feature to just call out for the relevance of HPV testing is there's been a global effort to push towards cervical cancer elimination, calling out some targets that countries should pursue in order to get to that elimination level that Dr. Laya mentioned earlier about incidence. That really countries' cervical cancer programs want to progress on vaccination, which many countries are doing quite well on. They want to progress on getting to screening coverage, 70% screening coverage for target population, and then 90% treatment for women with precancer and with those with invasive cancer that are managed. Many countries have made great strides in the vaccination side, but screening is lagging. And we're starting to see that to pick up where ministries are prioritizing how do we actually scale up HPV testing? What's the right technology for us? What are the enablers that can drive wider access and equitable access for women, thinking with a gender lens sometimes that way. But then also after testing, what's the linkage to care? And so anytime HPV testing comes up, you always have to think about the next step. When you get a result, how's that going to be actionable for a clinician? And how do you make it so that that testing service is feeding into the actionable clinical decision for treatment or for further follow-up later on? Next slide, please. So I'll just mention that beyond there being this elimination effort, there are some guidelines that sort of serve as a backbone to inform how we think about programs using HPV testing, where and how they can do it. HPV DNA detection is the preferred primary screen that the WHO calls out as your screening test. Countries should think about where they have the funding to transition to that from their VIA, which is visual inspection using acetic acid. We'll get into these methods in a minute. The other key thing that's come up in the last few years that enables HPV testing is self-collection. There's been a lot of studies about allowing clients and patients to collect the sample themselves from their cervix and seeing really robust, good performance with the DNA test technologies that are out there. That there's not a sacrifice in performance that comes with that. and it's viable to use at scale. And that really could open up a lot more access and coverage for screening that can matter. And we'll talk a little bit more about that. Obviously, the guidelines talk about the general population that you should target, really looking at, women age 30 to 45 in particular, and women living with HIV, maybe a little bit younger and a little more frequently that you want to get HPV testing done because they're at higher risk. The other elements that drive thinking about HPV testing are there are some public guidelines about, or I shouldn't say guidelines, I should say product profiles that inform developers of tests, manufacturers of tests, about what kind of tests they should focus on. What would actually be useful for deploying in a program setting? And the two kinds of tests that have come up most clearly and most often are really about thinking of tests within the lab, HPV tests that can be run in a lab that has controls and has the right sort of infrastructure and power and training. And those are typically higher throughput instruments that can run, they cost a bit more, but they can also run 50, 100 tests at one time. And those should be compatible with self-collection, but also tests that maybe are more point of care. You wouldn't need them in a lab setting. You can use them at health centers or health posts. Maybe they don't have the same power. They need simplified operation and have a lower cost, but bring access to testing closer to the patient. But both of those have a role to play, and I'll give some examples about how different ministries of health have thought about rolling out each of those. The other thing I'll call out is the WHO does have a step-by-step guide to encourage HPV scale-up planning. And it talks about the ways that you can do planning with different stakeholders, decide on sort of the delivery model to use, how to select different products and cost it, how to implement that program, and how to monitor it. And I really recommend looking into it. It's really helpful reference. And most of the ministries of health that we work with have used it as a tool. Next slide, please. Okay. So what we'll talk about today, and most of all, is the DNA testing for HPV. But just to comment that when you think about cervical cancer, the main ways that come up for how people look at screening are molecular testing, meaning you're getting the DNA or the RNA of the sample of the virus, and you're using a machine that allows you to replicate that many times, to multiply it and look for a signal that tells you there's the right kind of DNA markers for the HPV and to actually get a genotype from that. That's how we figure out if there's 16, 18, 36, etc. That's compatible with self-collection, which I mentioned. You get really reliable performance, high sensitivity for that, meaning that you're not missing cases when you're getting screening done. You're actually catching almost anybody who could have it. You might also have a few more false positives, or sorry, that's why you want to follow it up with the sort of triage after that, because you're catching everybody who might have it, and not missing them. But you also need to make sure that they actually have precancerous lesions, and so we'll get into that. The other two ways that you want to consider, or most countries look at screening, are cytology, often through Pap smear. Some countries like South Africa also use liquid-based cytology. That has a lot of variability in its performance. That depends on the training and the practices of individual labs. You use some of the same sample. You're scraping cells with a brush and then putting it under a microscope often. It has a moderate cost. It's not too expensive. HPV testing tends to be a little higher cost depending on how you add that up, but the performance is quite variable and you need a lab really to manage that. Finally, there's visual inspection. This is probably most common in most countries. It also has really high variability depending on the training of the staff that are running it. Ministries like to stick with it because it's low cost, but there's a high risk when you're letting patients go away until their next visit if you haven't actually identified whether they're at risk. And that's really the value of using HPV testing. There are some new softwares that are AI-based that are looking at improving VIA that can complement HPV testing, and that's what we are calling AVE. It means automated visual examination, where you can use a smartphone to take a picture of the cervix. And because of the large library that is trained on understanding where there's actually precancerous lesions or not, you can get better performance, higher sensitivity, and higher specificity than when you don't have that software in place for visual inspection. So the future that WHO is looking at and many ministries are considering now is there a combination of this HPV testing as screening and the visual inspection or automated visual as a triage to figure out if somebody's having precancerous lesions or at risk to manage care. Next slide, please. Okay, now I'll get a little more specific on HPV. It's worth calling out that across low and middle income countries, there are many, many, many platforms already installed that can run testing. We've done some worked with a number of ministries across different geographies and found that there's over 18,000 NAT platforms placed, mostly PCR, but some of them isothermal amplification. But these are instruments that can run DNA testing, and that many of them have capability of running HPV testing. These are instruments that can run over 13 million tests a week. A lot of that capacity was leveraged towards COVID, and some of it now is used for HIV viral load testing or TB molecular testing as well. But there's a lot of capacity. There doesn't need to be a major investment in new NAT platforms to be able to provide HPV testing now. It exists in the continent in a range of in Africa, but also South Asia and Latin America. It exists in the labs. There's trained staff who know how to use these instruments. And there's some HPV tests that can actually be used now on those where there's a will, political will, and funding to support it. So just to call out some of the range of products that are out there, we mentioned some of them here. There's HPV DNA tests that can run on these platforms. There's also mRNA that can run on some of them. DNA is usually preferred for women living with HIV and self-collection. They're usually more sensitive and more reliable. These tests have a different range of what they provide in terms of genotyping. Some of them tell you individual genotypes so that you can have that specifically for understanding care in your own sort of epidemiology and country. Some of them do pooled detection, meaning they tell you whether you have one of a group of genotypes rather than the specific genotype you have. And it sort of depends how you want to manage your care program to use those. Most countries want to know specifically the high risk ones by number, but maybe the low risk ones maybe don't always need to know exactly the genotype. The throughput, meaning the number of tests they can run per instrument, varies quite a bit. Some of them run 30 tests per batch. Some of them run 100 tests per batch. And usually the results come in 2 to 4 hours, depending on the instrument you're looking at. So in the course of a lab's day, maybe an 8-hour workday, you can run quite a few tests. And each ministry that we work with and each private hospital that's looking at this has to decide what instrument fits their capacity. How many patients are they seeing a day? How many samples? What's the right instrument that fits what they're doing? Really, one of the key features we'll get to in a minute that ministries think about is about how do we get faster results for a clinical decision? Can we do same day management of care here rather than doing multi-visits for patients? That's a key feature. Another difference across these products is random access. Some products will run a big batch all at once, 50 samples. Some of them allow you to run 10 samples of one type, 10 samples of another type, or just do one sample at a time. And that's what we call the ability to get results for single tests rather than needing to do large batching. All these platforms can run multiple different DNA tests. They can run, like I said earlier, HIV, TB, hepatitis. And so one of the key things that programs that want to do more HPV testing should do is think about where the instruments are already in place and used for these other diseases, but have capacity to do HPV testing. Finally, there's a big range of costs, and we'll get into the specifics there. Some of these tests in terms of reagents are as low as $5. Some of them are up to $15. But when you think about costing of HPV testing, you have to think about more than just the reagents, the individual chemicals for the individual test. You have to think about the consumables. You have to think about the instrument costs. You have to think about the import costs and all that. And we have some references for that. Next slide, please. Okay. I won't spend too much time on this. This slide and the next slide just give some examples of the different suppliers for these tests. These are what you might see in your own lab, in your own hospital, in the country you work in. You may have heard of Abbott and Roche and Hologic and BD. These are rather large companies that have had a footprint in many high burden, low middle income countries for years, placing these instruments often for HIV viral load testing. Most of these do DNA testing. I'll flag the Hologic Aptima test uses mRNA. And you can see here the different genotypes they do, the different throughput they do. Some of them do 96 tests at a time. Some of them do 300 tests at a time. All of these have WHO PQ. I guess Hologic hasn't gotten theirs or have just gotten theirs this year, or they've gotten another stringent regulatory authority approval like FDA or CE. And you can see there's a wide range of pricing across these. The BD test price is $13 a test. The Abbott real-time PCR is $624. And we'll get into a little more specifics about why there's such a range of those. Next slide, please. So those were a list of the big instruments that run high throughput. and you place it that require a lot of infrastructure to be in place. You'd place them at a regional lab or a regional hospital or a national reference lab. But there are other products that can be used in more decentralized settings that can be used at district hospitals and some in the future that maybe can be also used at health centers that provide this sort of DNA testing. I think most people will be familiar with the Cephia GeneXpert test. That's very commonly used to help drive more point of care testing results for patients. There's that gives DNA results, that has PQ. It's also a very expensive test. Then, of course, there's QIAGEN, Attila, Amplifier, and some more that are coming in the future that promise to be a little more decentralized. I'd say they're a lot like the Cephia GeneXpert. They're kind of you don't need a lot of sample prep. You don't need like a centrifuge to run them or anything. You get the swab, you put it in a tube or a cartridge, and you put it in the machine. And that offers the ability to have a wider set of stakeholders provide that test. Next slide, please. Finally, the other consideration here is self-sampling and how do you get the sample collection. HPV testing is often driven by who actually can provide a sample and when. Self-collection has proven to be really, really positively responded to by patients. They see it as a chance to maintain their privacy and provide the sample, but also it has really good performance on these DNA tests. So we think it's a really critical tool for driving broader coverage and access. In the 10 countries we work in, 8 of them have already adopted it in their policies as acceptable, and it should help enable much wider ability to get samples and bring it in. There are a bunch of devices on the market that enable this, that allow for the right sort of brush or swab to collect the sample. There are some challenges that are still worth getting some evidence on about how to transport that sample once you get it. There are dry and wet media for managing that can help simplify the logistics here, and they have a range of costs. And really getting clear evidence about how to maintain a stable sample but get it into a testing lab immediately is really the challenge moving forward. Next slide, please. Okay, so it's worth calling out some of the success here. Actually, there's been a lot of expansion and use of HPV testing in the last 5 years. Turkey has done some national scale up, launching tenders for 15 million tests to do national level screening. Places where we work do some decentralized testing and centralized testing via GeneXpert or the Abbott and Roche. It's common now for quite a few countries to integrate that screening into other services, so to bring it into ART clinics where people living with HIV are already getting care regularly and are sort of a captured population, into family planning clinics, MNCH sites, and bring the sort of sample collection as well as sort of the screening into that process, as well as community mobilization. It's not always that you can catch the right population at the facility. You have to bring the opportunity to them, and that's where self-sampling really comes into place. You can allow somebody to do it in the comfort of their own home to collect a sample and get it into the lab to run. So I think some of the key findings that you see in published literature now across all these countries is integration is totally possible. HPV testing doesn't have to create its own pathway. It can build on where there's already investments in taking care of patients for HIV, taking care of patients for family planning, et cetera. And you don't need additional HR for that. You don't need a complex supply chain or lab infrastructure. There's already a set of instruments and a set of patients and management that's occurring. Self-sampling is feasible. We've seen it done in quite a few countries now and published evidence that it's possible. You don't have to sacrifice on performance. You can still catch patients when you need them. And it's moving towards same day sort of test and treat or test, triage, and treat is really a goal here. That there's a lot of loss to follow-up that can happen for patients if you are sending a sample away for testing or you're not following up with them in a consistent way. And it's really important to figure out ways that after you've gotten a positive result or brought them in, that you're doing triage or getting to treatment in a way that keeps the patient in the health system and getting taken care of. Next slide, please. Okay. I think we've talked a little bit about near point of care versus centralized systems. Zimbabwe has really scaled up their HPV testing in the big labs that they run, where they can do high volume, low cost testing, HPV testing on the Hologic Panther. They get their results returned to patients through SMS. And that's one of the ways that you can deal with having to refer a sample to a lab. They're finding that works quite well for them. And they can also remind the patient about their next appointment from there, which works. And they have a lot of open capacity. They have these Hologic Panthers that they used for HIV viral load, but it turned out they had 25 or 30% of capacity available to do HPV testing. So the government doesn't have to buy any new instruments. They can start scaling up testing immediately. Same thing's true in Uganda, but focused more decentralized. The GeneXperts that they have in place, for TB testing have open capacity. They were able to start doing HPV testing for women that were going to get care at ART sites and provide same-day test results right there. The key challenge, obviously, is what you do for healthcare workers when they have to follow up then and there. If somebody's getting that positive result, and you have to do a triage at that point to figure out whether they're precancerous or not. That requires more work from them as well. So you have to think about beyond just the testing and what the implications are for more HPV. Next slide, please. Yeah. So finally, I'll mention just pricing. There's a wide range of pricing for these tests. The blue bar is what just the reagents are, which is what most people think about when they're buying an HPV test, just the commodities for an individual test. But actually, there's so much more that goes into it for lab costs, service and maintenance, supply chain, and that can be hidden. And so if you really want to scale up HPV testing, you have to get clarity and transparency on those costs. And it's something that we try and publish evidence on and actually host some of the data on this on the WHO website so that people can reference it and drive better negotiation with suppliers to get more competitive prices. The Abbott real-time really should be one that all these suppliers provide that price point, $6 rather than $8 or $14, and we want to enable that. Next slide, please. John Black, do I have 2 more minutes or would you like me to wrap up? I realize we're nearing the hour.
Yeah, you can complete.
Okay.
For me, this
We'll
is
share
very
it.
interesting, and I think it is also interesting for everyone.
Okay. We'll of course share these slides after, and I'm happy to be available beyond this to talk more specifically. But it's just to say kind of a buyer beware about these tests. They have WHO PQ, they're quality and reliable, but you can see here with the green checks and the red X's that they don't offer the same thing for a price point. They'll say, I'm cheaper than this other one. But when you look at what you actually get for that price point, it maybe doesn't include all the things you need. So the Abbott $6.24 price on the far left gives you the reagents and the consumables, but doesn't include the instrument. And so you have to pay for that separately. But the Hologic $9 price, which is the third or fifth column here, $9 covers everything. The reagents, the instrument, the service and maintenance, invalid results. They'll get it through customs and clearance, the freight to bring it down to the site. And so it's more easy to plan that. And it really helps to compare these when somebody's offering you a price point to look at the real details and to bring in some of the lab staff that know these things backwards and forwards to make sure that this isn't missed. And that's a really important thing when a program for HPV testing is getting off the ground, trying to budget appropriately, make sure they assign the right things, that can be missed. Next slide, please. Okay. Yeah, most of these suppliers have access programs where they offer supposedly good prices for LMICs, but you can see here that it actually differs by geography quite a bit. And so again, it's one of those things where you see a sticker price where they say, you can get X from us, but it's hidden here. And I would say this is a key area that really any partner that engages with a supplier should try and push for equity. All of these countries deserve to have access to the pricing. And if we build demand together for HPV testing, we think it can influence it. Next slide, please. Okay, we talked about some of these things that influence pricing. Sometimes it's fragmented procurement. So instead of having a single buyer or multiple, like big, large scale buyers, there's lots and lots of small buyers of HPV testing right now, and that impacts the prices that we're seeing. The other things that matter are these gap programs, these access programs aren't synced up across geographies. And so South Africa may get a good price right now, but Kenya doesn't. And that's really unfair. So we're trying to publish data on pricing where it's possible so that anybody who's procuring can use that as leverage. And we hope that the future is that there's some pooled procurement across people who are buying the tests that can work together to drive better pricing. Next slide, please. Okay. So I just want to call out some of the big wins for HPV testing because it actually has gone from something that didn't really happen a lot in LMICs to seeing a lot of investment and a lot of progress that really matters. First of all, before 2019, the average price was over $15 per test just for reagents. Now that's closer to about $8.80. There are access programs that are publicly available. There have been major reductions in the price per test for doing HPV testing over the last 5 years or 6 years that are close to 25% where it used to be. The WHO has actually PQ'd quite a few more products, meaning pre-qualification for many countries is used as a regulatory authority sort of approval. And when something has PQ, they feel more confident that it has the right manufacturing quality, it has the right performance. And there were 2 products before 2019 that were PQ'd, and there have been 6 that have been added since then, which is great. That means there's a wider set of competitive market to draw on for anybody who wants to do more HPV testing. Self-sampling is now validated and countries can feel confident about introducing it and using it. There are at least 8 countries that have adopted it into their national policies and starting to use it. There's 4 or 8 different products that enable the self-sampling, and we know what those kits cost and look like. That can be $1.50 to $3.50, depending on where you go. There's more money and demand for HPV testing. There's PEPFAR and Global Fund both have allowed some HPV procurement within their own budgets. There's more domestic financing that's going into it. And many countries are actually setting testing targets now. So you'll start to see more countries that say, I want to test 100,000 women, 300,000, 500,000. I think there's somebody on here from Rwanda. The Rwandan Ministry of Health is testing, I think, 1.5 million women over the next year and a half to progress on elimination. So there's a lot of momentum, and there will be learnings from that come and tell us how HPV testing at scale really works. There are different implementation models that are already starting to get published evidence about doing centralized testing and how to pair that with, say, SMS result delivery. There's also near point of care testing that's in place, and some community self-collection that's in place. Some combination of those models can make sense in different ways for different countries. Finally, there are national guidelines. Many countries have updated their guidelines in the last 5 years. Some of them have costed out action plans to actually deliver HPV testing, and that'll translate to a scale up of using these technologies. Next slide, please. Okay, last 2 slides. I want to just call out a couple of the gaps and challenges for HPV testing moving forward. The current coverage is low. Like the goal is 70% to get to elimination, 70% screening coverage, but most countries are really in the 0 to 5 or 0 to 10% screening coverage level. So we need to see, in order for governments to realize where they want to go on screening, HPV testing will have to increase quite a bit. The plus side is there are existing technologies people know how to use. They have capacity already. Prices are coming down. We know where women are seeking care and how to find them. There's self-sampling available. There's a lot of tools that mean that actually scaling that testing is really feasible. It does mean that beyond testing, you always have to think about what you do after the test. And so it's worth calling out the linkage to care as an issue. You really have to always think about when a result comes back, how do you make sure a patient and a clinician can act on it? And we need to see more equitable prices for people so they're not paying just because you're in India instead of Kenya that you're paying twice as much for these tests. Next slide, please. Okay, last one. Just thinking about the future a bit, I want to call out that there's really great research, probably by some people on this call already, that have done what is going to make a difference in the future. The self-collection, getting that scaled up, that is building on the shoulders of the work that people have done in the last 2 or 3 years to prove that self-sampling can work, that patients like it, and that there are ways to manage that sample moving forward. We really want to see that cost come down and to see that scaled up to enable much, much more broader HPV testing. In addition, there are, hopefully as the volume of HPV testing goes up, we can see the prices for reagents come down, instruments come down, and be more competitive. And there are some new products that are coming to market that will be more point of care, that are smaller devices for doing DNA testing that you can place at a health center level or maybe bring to the community. And using those to bring access to women wherever they are and wherever they seek care, rather than forcing the woman to do multiple visits or go up the chain from a health center to a hospital, will help keep more patients in care and instead of losing them to follow up and bring care to where they seek it. Okay, I think that's the last slide. Would you mind going to the next one? Great. Thank you. Thank you for giving me the time. I realized I was talking a little fast, so my apologies, but keen for any questions and comments, and of course to build on what Dr. Laya laid out earlier about the sort of epidemiology and history of this disease.
Excellent. Thank you so much, Troy, and thanks, Laya, also for sticking around. This is very informative, very interesting for me. I have picked up a lot. I still have also a couple of questions that I would like to ask. But I think you've covered a great deal of the question that people had and also what we intended for this session. As we mentioned, we welcome questions from the audience. If you have questions for Laya or for Troy, and also if you just want to share your experience in the country where you are, what approaches you're taking, if you want to share those with the others, please put that in the chat. You can also raise a hand and someone can unmute you and you can speak. But as I wait for people to ask, I can also just ask a few questions that I have for you. And maybe this is related to what Jean-Paul has asked, which is what strategies can be implemented to strengthen HPV prevention among men? Because everything now is focused on women, Yes, we need to do more for women, but yeah, should we be testing men? And should we be testing for HPV in non-cervical cancer co- uh, you know, conditions? This is for both of you. I don't know who wants to start first to start on this. Daya, you want to go first?
Yes? Okay. So only in anal cancer. So besides cervical cancer, in the other anatomical sites, testing for HPV will not help us do anything because there are not standard protocols of how to test, validated techniques, what to do if we get a positive, no? So we will deal with information that will create us anxiety without having anything to do, except for anal. For anal cancer, last year there was a release of the IANS about the screening for high-grade anal preneoplastic lesions and anal cancer for specific risk groups.
Bueno, if you have it,
In these recommendations, you have the different risk groups that it's recommended to screen for anal preneoplastic lesions and cancer, and also how to do it. That it's not so well established like for cervical cancer.
Yeah.
So there is still, we are still needing evidences and further studies to have a right and common protocols for anal HPV screening.
Yeah.
Because in some places they use anal high resolution anoscopy, other places also anal cytology, HPV DNA test.
Just have to be aware that it is possible to develop this cancer, but we cannot screen for it because there is no established protocols, and maybe people should be looking into those, into how best can we test and how what do we do. It's normally people say that cervical cancer is a fairly generous cancer. It gives you a lot of time from when you get the HPV to see the evolution, the precancerous changes, and so you have time to act. But it doesn't seem to be the case for the other non-cervical conditions. Okay, I think that answers Jean-Paul's question, and partly answering mine as well. Please put your questions in the chat, and as indicated, you can actually now unmute, raise your hand, even turn on your video and ask or give a comment. But I will also have another question for Troy, which is the idea of pooled testing. You mentioned pooled testing, but this was, I guess, in, as you called it, random access for the machine if it can run one test. But I'm thinking about pooled testing, like what was done in the COVID when let's say if you can, basically you put the samples for multiple people in one tube and test them. And then the idea is that if one of them is positive, then you can, begin to disentangle who caused the positivity out of, let's say, 4, 5, 10, depending on the size of the pool. But if you put 10 of them and they are all negative, then you can save, instead of testing 10 people, you've now used one test. Is that a thing that can happen in HPV?
It's a great question, Dr. Jean Black, because it can be a way to be more cost effective, to not need as much of a budget to run as many tests. Unfortunately, the math on that is a little difficult, and it looks like it doesn't save money for ministries because it depends on your positivity rate. Currently, most of the HPV testing programs are seeing a 20 to 30% positivity, well, 15 to 30% positivity rate for the women that they're screening. That may be a little bit of a biased sample because a lot of them are women living with HIV at higher risk, and so that could come down as general population screening happens. But when the positivity rate is over 10%, then you end up having to retest so many people after you've done a pooled sample that you don't end up saving any money. And you've created this sort of operational complexity for managing that. But
Yeah.
it is possible when the positivity rates come down. So as we progress in these programs and vaccination programs continue to progress, it could be the future to make that more affordable. And the results can be great. It means that you can focus when you have limited resources on something else. You can focus on education programs. You can focus those lab resources in another way.
Yeah, thanks. Thanks, Troy. So yeah, we have so much HPV we can't do pool testing, essentially. We have a high positivity rate.
Yeah.
We need to first take that down and then reduce the need, and then we can even save more in that sense. Okay, I see a question also from Kudzai. What are the current recommendations with regards to HPV vaccination for boys in LMICs? Troy, you want to take that or?
Yeah, I focus on diagnostics, not vaccines, but my understanding in most of the countries we work in is that it's still focused on just women, and the idea of extending it, or girls, excuse me, and the idea of extending it to boys is not widely accepted yet. There is some challenge with vaccination program buy-in still about the idea that it promotes sexual promiscuity, and there's some moral sort of perspectives that people have about that impact the ability to see that fully scaled, and that extends to boys. That they say they think this is a cancer that only affects girls, and it doesn't affect boys, and so when we do this to boys, we're promoting the same issues. But I think your earlier framing about why HPV can affect so many people in a range of ways is really critical and should help people unlock the value of including boys in those programs.
Yeah, indeed.
Yeah.
In other countries, they are already testing boys. I know, for example, that in Sweden they do. They vaccinate boys. Sorry, not testing, but vaccinate boys. In the Netherlands, they do, and there was been some studies done on this issue that it promotes promiscuity. I think this was done in Canada, and there was no evidence at all that indeed it increases, the sexual promiscuity for girls and boys. Maybe we need to get this evidence as well in Uganda, in Kenya, in South Africa, and see. But I also think that one of the issues is the availability of the vaccines, because now you have twice the population to vaccinate, and we need to make a stronger case for why there should be more investment in that.
Can
Okay.
I say something about this?
Yeah, yes.
No, it's
Glenn.
only to complement and is following the same direction. And that's that the recommendations are we are going for a gender neutral vaccination, but of course, depending of the resources, we have to prioritize girls, young girls. But if you, depending on the resources of the country and other issues, then if you are able, the thing is to include also boys.
Yeah.
But
Indeed.
always prioritizing the girls first.
Yeah, they have the highest risk
Mhm.
indeed, so they should get the priority. Okay, so I think we're coming to the end of the scheduled time, and it's nice that there's been a lot of attendance. I assume you in the audience you're enjoying this presentation as much as me, and you're learning from it. And I think that's also why you're sticking around towards the end. But without new questions coming in, I think we should be coming to the close of the session.
Dr. John Black,
Maybe
I did
one.
I did
Yeah.
see one quick question that I can address if you don't mind.
Yeah.
From Sandhya Singh. It was a little earlier
Oh,
about asking about, are you aware of any research done looking at screening results of young women who receive the HPV vaccine as girls? I haven't seen evidence of that in low and middle income countries. I have seen it from some higher income countries, and it said a couple things that I think you would probably expect. Well, one is that these DNA tests are still just as reliable for using with that population. There's no impact to their performance, and so that's part A. Part B is that the clinical guidelines are to still maintain the screening even for people who have gotten the vaccination. That it's the cases for people who have it are way down for SIN2 or SIN3, an actual progression of cancer, but it's still possible, it sounds like. Yeah, did that address it, or am I missing something there, Jean-Blac, that you would add?
Yeah. Actually, I wanted to follow up on this as my very last question as we go is so looking in the future, because I mean we have this gloomy picture of there's a very big burden and we don't have access to vaccination and we don't have access to affordable screening, but there is also a positive picture that we're getting more and more access, like the slides that you presented last, which was we're getting more national guidelines, we're getting more manufacturers and providers of these. And for me, what that tells me is that soon we are going to get really in a better place with regards to prevention and screening, and so the numbers are going to go down. And then when I look at, let's say, places in the Netherlands, when you reach that situation, then you begin to weigh how you can de-intensify the screening, because at that point, then it begins to become less cost effective. Maybe you need to screen some people fewer times, let's say every 10 years instead of every 5 or every 3 now. What I've seen, what sort of makes me worried is that we will not have a basis to make these decisions, especially if we don't have nice data systems, if we don't have screening registries, if we don't have medical records and things like that where we can say, how do we risk stratify and say, for this woman, we can just let her go and we screen her after 10 years to avoid over screening and making them worried and the cost of it. While for this woman, we need to screen her every 3 years. So that kind of personalization and risk stratification, for me, I think is something that we should also begin to think about. It is not yet an issue, but it's going to be an important issue. I don't know if you have any comments on that. No?
No, I think that's well said. I don't think I can add more nuance. I think you've captured it really well.
All right. Okay. I think we should come to a close of this interesting discussion. Thank you so much, Leah, and thank you so much, Troy. And thanks everyone for joining the ECHO Secretariat that has been doing the correspondence, for scheduling, and of course for everyone who has been part of the ECHO. I would like to give to Charles the mic to say some closing remarks. Maybe you have information about the upcoming ECHO. Oh wait, Sam, you have oh yeah, you will do the closing. Yeah, I allow you, Sam, to do the closing. Charles, you are off the hook.
Not a problem. Thank you, Dr. John Black, for the session today. Definitely Charles will mention something about next month. But as we come to the end of today's impactful session, I would like to sincerely thank our moderator, Dr. John Black, and our presenters, Leah Limani and Troy Marrell, for their insightful contributions and for grounding this discussion in both global evidence and practical realities for Africa. And definitely I've been listening in the whole session, and the session has reinforced a critical message. HPV-related cancers, particularly cervical cancer, are preventable, yet they remain a significant public health burden across Africa. We've heard clearly that prevention, early detection, and equitable access to diagnostics and treatment must go hand in hand. From vaccination strategies to screening innovations and diagnostic access, several key reflections stand out from what I picked up. One is prevention is our strongest tool. Screening must be accessible and context-specific. Diagnostics and treatment equity matter. And last and foremost, data and collaboration drive impact. Importantly, this session also reminds us that community engagement and patient-centered approaches are central to success. And not forgetting that we need to address stigma, improving awareness. I'm also a global patient advocate, among other things that I do in community. And ensuring culturally appropriate communication will determine how effectively these interventions are adopted. And of course, within the African context, we must continue to ask ourselves, how do we translate knowledge into sustainable, scalable action? And how do we ensure that no woman, no child, and no community is left behind? And that is what we are doing through this platform, through this Project ECHO platform, where we are not only sharing knowledge, we are also building a community of practice committed to equity, capacity building, and real change across the continent. So definitely, as we move forward, let us carry today's discussion into action, into our clinics, into our programs, into our policies, and into our communities. So thank you all for your active participation, your questions as well, seen here in the chat box, and also your commitment to advancing cancer control in Africa. And together, we are truly united against cancer. Thank you very much, Dr. John Black. And I'll definitely hand it over to Charles as well, if he has something to add about the program for next month and so on and so forth. Thank you as well to the KENCO Hub.
Yeah, so thank you very much. I have nothing much to add, just thank the speakers and Dr. John Black for taking us through the session. Yeah, this is a continuing series, and we'll have our next session next month. That is the last Thursday. So please look out for the details. We have a steering committee that has been driving this, and we're going to be meeting soon to decide on the focus for the next session. So we'll update on ECHO, and we hope that you'll be able to join us. So thank you very much, and have a nice time.
Thank you. Bye, everyone. Look out for the communications with regards to the next session. But for now, have a good evening, good morning, good night, depending on where you are.
Bye.
Bye, everybody.
Bye-bye.
Bye.